Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello everyone, I am Fernando López Ríos, Chief of the Molecular Diagnostics Service in the Department of Pathology at Hospital Universitario 12 de Octubre in Madrid, Spain. So welcome to this Medscape program titled Delivering Precision Oncology to Patients from Principles to Practice. So I'm really happy to share the stage today with Alison Schramm, Section Head of Oral Therapeutics at the Early Drug Development Service and GYM oncologist in the Department of Medicine at the Memorial Sloan Kettering Cancer Center in New York. So welcome, Alison. How are you doing today?
Thank you, Fernando. It's good to be here today. I'm doing well.
Today, we are going to discuss the rationale to using molecular profiling to guide cancer therapy. We will also explain how we identify patients who may benefit from targeted therapies and how can try to improve the current process. Because I don't know if you agree with me, Alison, but there are still some challenges that we need to overcome. And finally, in the last part of the conversation, we are going to talk about molecular tumor boards and their role in making sure that all patients are receiving the best therapy available. So let's start by asking you, Alison, a general question. Which is, what is the rationale behind implementing molecular testing in oncology care? Because I think in the past 2 decades, we've seen amazing results and incredible drug development efforts. But what's really the science behind this paradigm shift?
Yeah, thank you for that question. So, over the last many years, as you mentioned, there has really been a paradigm shift in oncology, I would say. And we typically classify cancers based on their site of origin, whether they came from the lung or breast or colon. But there's really been a shift in our thinking. And now tumors are defined not only based on where they're from, but also based on the molecular profile. So that's the DNA, RNA, proteins, and other molecular factors. And so molecular testing has really become an integral part of our armamentarium in terms of understanding cancers. And so this testing is important for disease prognosis. There are some genetic alterations that confer a better or a worse prognosis. It helps with diagnosis in some cases. There are certain genomic alterations that are pathognomonic for certain diseases or certain profiles that you might expect to see in a certain disease type. But most importantly, these genetic profiles can actually help dictate our treatment now. And there are genetic alterations that you can find in a tumor molecular profile that confer sensitivity to certain therapies. And conversely, there are also alterations that can confer resistance to certain therapies. So this is really critical when making decisions about our patients. The clinical trial landscape is also evolving a lot, and a lot of our clinical trials are using molecularly targeted therapies, trying to develop a better biomarker-driven approach to cancer drug development. And so these molecular profiles have become very important when identifying patients who might be appropriate for clinical trials.
I can only add that in my perspective, something that is also changing the way we treat cancer patients is that now we are also including patients in earlier stages. So it's also a different way of thinking, because then we are actually trying to obtain predictive biomarker information in all of our patients.
Absolutely. And as a GYN medical oncologist, recently the staging criteria were actually updated to include molecular pathology. And so we take this into account when deciding what types of adjuvant therapy to give patients. So I completely agree. In earlier stages, this is becoming especially relevant. So in terms of the, as a pathologist, in terms of the current approaches for testing, there are obviously a lot of different available molecular tests for cancer genomics. And I'm just wondering how you think about these various assays.
Okay, I think the first comment is that now that we are not all in love with next generation sequencing, NGS, we should not forget that there are other ways of running our predictive assays. For example, immunohistochemistry might still play a role now with antibody drug conjugates, or in some regions, single gene assays or single gene approaches are still a very valid option. But let's focus on NGS for the moment. I think right now the two technologies that you use are amplicon-based NGS and hybrid capture NGS, and they both have advantages and disadvantages. For example, input material is much less for amplicon-based NGS, and turnaround time is also probably less, but usually larger panels are run using hybrid capture technologies. So you have to really understand what you need, and when you are in front of an NGS report, or when you are trying to implement or challenge sometimes an NGS result. And finally, I think this controversy between in-house assays versus commercial assays that are run in outside vendors or facilities, I think it's no longer something that is benefiting our patients. We just maybe have to understand what the advantages and disadvantages of the different options are. And finally, I would also like to emphasize how important it is to probably try to use DNA and RNA when you're running these assays, because we now know that RNA-based NGS is more sensitive, at least for the detection of actionable fusion. So if you have the option, it's better to run a DNA and RNA panel. If you only run a DNA panel and the result is completely negative in some tumor types, might be a good strategy to afterwards try to reflex to an RNA-based technology. I'm curious because as a pathologist, sometimes I don't know how much information I should put in my NGS reports. So what are your thoughts as an oncologist? How much information do you like to see in your reports?
Yeah, that's a great question. And these reports have become longer and longer, and it's great to see that a lot of information is being included, but sometimes you can get bogged down when you have a 100-page report. So I think it is important to, to really understand what is being offered in a report. The things I like to see, so typically when I get an NGS report, I will first look and see, what is this telling me and what is this not telling me? What are we looking for? Is this DNA or RNA? And if it's DNA or RNA, were there certain exons included, in which genes were included, first of all, and then, and beyond just which genes, are there just certain exons included, so that I really get a sense for what was looked for and what was notably absent in what we were looking for on the given report. So what testing was done, what was looked for, what was not. Beyond that, looking at the NGS panels, which have become quite large on these reports, often more than 500 genes. I like to see, what are the genetic mutations? And typically the things I look for are there any genetic mutations that confer sensitivity to a specific therapy and an approved targeted therapy in this patient's histology and their tumor type. And beyond that, I look to see, is there a genetic mutation that would confer resistance or is likely to suggest inactivity of a drug? And then looking at the report, there's typically a list of other alterations. But I think what's really helpful is knowing how likely are these to be driver alterations? So in addition to just listing the specific genetic changes, it's really helpful for a clinician like me to have some additional metadata that actually gives some annotation of the genetic alterations. Are these known to be drivers? Are these hotspot mutations, meaning that they're mutated more frequently than would be expected by chance alone? And that hotspot annotation suggests that there's a selective pressure for that mutation, meaning it's likely to be oncogenic. Is this something that appears to be clonal? So if you look at variant allele frequencies, is this something that appears to be in all the cancer cells? And then oftentimes we will also get information about potential clinical trials on the reports themselves. And so this has been a huge advance over the last couple of years, where you actually get listed potential clinical trials for a given alteration that might match a patient based on their genetic report. And there can sometimes be a long list of these trials, and it can be difficult to tease out, but it does give us a starting point, particularly if you're in a community oncology center that doesn't necessarily have access to clinical trials at your own institution. It can give you a means to identify patients for clinical trials around the globe. So those are some of the things I look for. In addition, just to get a sense of the quality of the specimen, I look to see, does it have a purity listed somewhere? Do we know that this was a good sample? If it's just a straight kind of negative report, is that because the sample wasn't of good quality? And then the other thing I generally look for is, does this make sense with the tumor type that we have here? So if this is a high-grade serous ovarian cancer patient, for example, we expect p53 mutations in essentially all of these cases. And so if that's absent, it makes you wonder, either was there something wrong with the test, or is this not truly the disease that we thought it was? So just making sure that the genomics makes sense in the larger context of the patient.
Completely agree with you. And I think in summary, probably more standardized reporting could help in the field, and also a deeper understanding of the design and the advantages and disadvantages of the different testing modalities. So completely agree.
Absolutely. Yes, I completely agree. And speaking about, the advantages and disadvantages of different testing reporting, there's also, various ways of getting genetic testing. And so we've discussed tumor biopsies, and most of these genomic reports are based on tumor biopsies, but we have also developed several technologies over the last couple of years to look at things like liquid biopsies for molecular testing. And there are several commercial companies and homegrown assays looking at liquid biopsies. And I'm wondering your thoughts on that technology.
Well, I think the potential role of liquid biopsies is huge, from minimal residual disease to all the way to trying to find therapeutic targets in patients with advanced disease. So we need to understand that when you say liquid biopsy, it's not only blood, where we separate the plasma and we look for these targets there, but also other sources could be pleural effusions or central nervous system fluids. So we need to think of this as a huge opportunity. And I think that the main advantages is that this is very convenient for patients, and probably turnaround time is faster than tissue biopsies, because you don't have to process the tissue and extract DNA, RNA, etc. The main disadvantage is that in many cases, sensitivity is not very high. So if you obtain a negative result, then you might end up having to rebiopsy the patient. But again, I see this liquid biopsy option as a complementary tool with tissue biopsy. I don't like when there is kind of a competition, what's better, what's best. And I think we need to do a better job at trying to integrate the results from liquid biopsies and tissue biopsies. So now we have talked about the rationale behind targeted therapies and comprehensive genomic profiling, the different testing modalities, including liquid biopsies. But what about guidelines? What are the current guidelines recommendations on molecular testing?
Yeah, so in terms of guidelines, there's a variety of guidelines when it comes to molecular testing, NCCN, and then some of the cooperative groups, the ASCO and ESMO, all have slightly differing guidelines when it comes to molecular testing. And I really do think there's a necessity for there to be some integration of these guidelines and some overarching guidance for clinicians. The NCCN does a great job of breaking it down by disease type. And if you look in the specific disease type guidelines in the NCCN, you do see there are these algorithms for genomic testing and molecular testing more generally, which include proteins, to really say these are the minimal molecular tests that should be performed in a given tumor type, and this is how you should do this testing. And in terms of ESMO guidelines, what is your experience with ESMO?
Well, I think probably a similar situation. At the beginning, we had tumor-specific guidelines that were driven by the different histological subtypes. But currently, the ESMO Translational Research and Precision Medicine Working Group has released a more general guidance on NGS for metastatic tumors. So I think there is an obvious trend that is helping us understand that we probably need to start considering upfront NGS for most patients with advanced solid tumors. And alongside this tumor agnostic perspective, there are also guidelines on specific biomarkers, for example, NTRK testing guidelines, RED testing guidelines. And finally, I think it's also important that ESMO is addressing the topic of liquid biopsies, because again, before I think we were focusing on specific tumor types, lung, for example, or breast, but I think it's good to have that global perspective with this new approach.
Yeah, absolutely, and I think it's important. I completely agree. I think it's important to state that ASCO and ESMO's guidelines have both indicated that it's critical to do molecular testing in disease types for which there is a biomarker that is matched to a standard of care therapy. So the guidelines state that if you have a tumor type for which there's a biomarker that would confer sensitivity to an approved agent, you should be getting that molecular testing. And so that really does span I would argue all solid tumor types at this point, because now that we have 8 FDA approvals for biomarkers in tumor agnostic settings, so we have 8 different biomarker drug pairs where the FDA has said, regardless of your advanced solid tumor type, if you have this genomic alteration or this genomic signature, this therapy is available to you. So now that we have these 8 tumor agnostic approvals, I would argue that it should be standard of care to get molecular testing in all advanced solid tumor patients.
So let's try to dream a little here. So this is what we all want, but what is the reality? So what is your process when you try to identify patients who might benefit from targeted therapies? How do you select your patients? Because again, we practice in institutions where we have access to NGS and we have a lot of resources. But can you give us some practical tips on how you do this, Alison, in real life?
Yeah, absolutely. So, I acknowledge that there's obviously a large spectrum in terms of the resources available to oncologists, and some of this is dictated by payers and insurance, and so it is quite complicated. There are many different tests that we can order, and they're not available everywhere. And so we do have to prioritize to some degree. My practice is to get molecular testing in all advanced cancer patients, but particularly those for which we know that it guides standard of care testing. So again, you can argue that's everyone, but there are clearly some diseases for which it is much more common to identify an alteration that will dictate treatment. And so, my process is to order usually large panel next generation sequencing testing, DNA-based assays, but increasingly I agree, it's important to do RNA testing, particularly for diseases where fusions are common. So things like lung cancers, where you really have several targeted therapies that are directed against fusions. It's really important to look for RNA. In tumors that are driver negative, where you might have expected to see a driver, you also wonder, can you be missing a fusion? And with DNA testing alone. And then in those cases, I also do RNA-based testing. Immunohistochemistry, as you mentioned earlier in this conversation, is again gaining increasing importance, particularly in the era of antibody drug conjugates, where the biomarkers in many of these clinical trials were actually protein expression by IHC and not NGS. And so while you can select out patients perhaps more likely to be positive based on amplifications in the NGS, protein expression is really critical in those cases as well. So I think, although we just discussed how this can really be a tumor agnostic situation where you do genetic testing on everyone, the reality is that it depends on the disease types. What is the absolute minimal amount of molecular testing that is needed? And so for ovarian cancer, for example, where I practice, we need to look for BRCA mutations, both germline and somatic BRCA mutations. That is absolutely critical for dictating care. We now have to look for HRD signatures in patients who are BRCA negative, and that also determines what standard of care is. But we're also starting to look for things like HER2 by immunohistochemistry and folate receptor alpha. And so that is more of an ovarian cancer specific molecular kind of guide. However, we are, I think, moving towards this more tumor agnostic approach to getting the DNA, the RNA, and the proteomics in all patients. So I think it really, to take a step back, it really depends on the patient in front of me. And so how do we use the reports that we get to identify therapies that are suitable for patients? As we discussed earlier, these reports have a lot of information. They can sometimes be overwhelming to read. And so in order to help us understand what is this report telling us, how can I use this to help my patient, we need to use clues. Often the reports themselves have clues. The biomarker for which there's an FDA-approved drug will be bolded, or there will be a little notation saying this is a level 1 biomarker that confers sensitivity to a standard of care drug, and they will call that out on the report. But sometimes you need to use resources beyond what's in the paper in front of you. And so I often use online resources, OncoKB being one of them, personalized cancer therapy knowledge base for precision oncology, CKB, MTBP. There's a long list of these knowledge bases that can really help us to interpret the data in the reports. And so that helps me to understand what are these genomic alterations and what do they mean for my patients? And also, how can I match patients to clinical trials based on the results of these genomic reports? So, in terms of these reports, as a molecular pathologist, I'm curious what you think in terms of when these should be challenged. How do we know whether we can trust a report when it's in front of us in terms of the information being provided?
Well, I think it is something that I keep telling my clinical colleagues all the time, that they should be able to challenge NGS reports, and sometimes we have oncology residents doing their elective rotation with us, and I think this is the main message that I want them to understand. As you were saying, I think it's very important to try to integrate all the information that you have from a given patient, the clinical history, the histological classification of the tumor, and then obviously the results. And you need to try to make sure that everything is within an expected range. I'm not saying everything is always perfect, and some things we are still trying to understand some of the findings, but you need to really make sure that you're not the first one in the world discovering something that has never been described. So very important, as you were saying, to make sure that everything makes sense. And then I think it's good practice here to know the differences between DNA-based and DNA-RNA-based NGS, as we have mentioned a couple of times. I think it's also important to make sure that the assay was run on a sample that had enough DNA and RNA content, tumor content. or make sure that the quality of that DNA RNA is within the expected range. So I think those 2 or 3 things are really important. And finally, if the result is inconclusive for whatever reason, sometimes you have a low number of reads in an initial NGS report. I think it's good to make sure that that you have access to orthogonal testing. And I think there's no shame on saying, okay, I'm not sure this result is unexpected, so I need a second or even a third assay. Sometimes a cheap IHC stain can confirm an actionable fusion if the number of reads, for example, is very low. So I think those are the things that we all need to know to be able to challenge NGS results, which at the end I think is good news for patients. So and finally, and this is my favorite part, let's talk about molecular tumor boards. So what is the role of molecular tumor boards? What's your experience? How do you participate in molecular tumor boards, or what do you think are the knowledge gaps in this field, Alison?
Yeah, so molecular tumor boards are becoming more and more common. And I think that this is really critical because of the complexity of the topic, and also beyond just how complex it is to match a patient with the appropriate therapy, is the idea that this is ever changing. This is a very dynamic field, and there are constantly new things being discovered in terms of biomarkers that predict for response to therapy, new targeted therapies coming out. And so whereas you might get a lot of information from a report, that report is stagnant in time, and you really need to be up to date in order to truly know what is the best therapy for your patients. So molecular tumor boards are usually a group of people that come together, medical oncologists, molecular pathologists, sometimes surgeons, radiation oncologists, pathologists that do more surgical pathology, and review the case, including the genomics, to try and match a patient with the most appropriate therapy, whether that be targeted therapy or standard of care chemotherapy or radiation or surgery. They provide clinical recommendations and guidance based on the best available data at the time, and they guide patients towards innovative clinical trials if there is a clinical trial that is appropriate for a patient's particular molecular alteration. And so by having people together in a room who are keeping up to date with the field, looking together at a genomic report and the patient's histology and their clinical context in terms of the prior treatments they've had, and together coming up with a recommendation is really critical to providing effective care for cancer patients these days.
I completely agree with you, Alison. Again, if I may add, I think it's very important also sometimes to make sure that we prepare for those molecular tumor boards in advance. So sometimes what we do is we have a formal meeting in the lab before we sign out our NGS reports. So that way we trigger orthogonal testing before discussing the case with our clinical colleagues, or we make sure that our reports are a bit more sensible and maybe we save time when we discuss them at clinical molecular tumor boards. I do believe that effective communication sometimes needs several layers of communication, because it's a very complex field, and it's not easy to make sense of that much information.
I just wanted to add one thing, which is that I know that molecular tumor boards are not available to everyone. There's a lot of community oncologists that maybe don't have access to the molecular pathologists and the specialists and the geneticists that comprise these molecular tumor boards. But this is somewhere where the online databases can be truly helpful. Things like OncoKB can serve as a sounding board in certain ways for, what is the data behind this genetic alteration in front of me. And so for those medical oncologists that don't have access to tumor boards, that's really where these knowledge bases and online resources are critical.
Yes, I'm very fond of OncoKB, and but I think we also need to convince everyone of the benefits of having a molecular tumor board. So So in a few sentences, what would you tell someone that is not convinced to try to overcome this challenge?
Yeah, I think the benefits are that it optimizes treatment for patients in an ever-evolving landscape of biomarker-driven therapeutics that we have now available. And so it really optimizes the interpretation of the genomic data. It identifies patients for appropriate targeted therapies, but also for clinical trials that they may be eligible for. And molecular tumor boards are also, as you mentioned, very helpful for identifying additional testing that might be helpful in teasing out the molecular results and trying to truly understand what is the biology of this cancer. Do we have something here that should dictate treatment or suggest benefit or lack of benefit of any of the agents that we have at hand? And so I think a conversation, a molecular tumor board is really the most up-to-date way of identifying the best treatments for our patients.
Well, thank you very much, Alison, for this great discussion. So and thank you very much for attending and for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation form. I did have a great time, and I think it was a very nice conversation that hopefully we will be able to continue in the future.
This program was presented by Medscape Education Global.